You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Ilyas, welcome to the Nailed It Ortho Podcast. So happy to have you on. So welcome to the podcast.
It's an absolute pleasure to be here. I'm really impressed with what you guys are doing and what an effective educational platform you guys are creating. So good job with that.
That's very nice of you to say. And so at the beginning of our podcast, we always start off asking our guests a couple questions, just getting to know them a little bit better. And we'll just start off with a general question: is what does your practice consist of now? Like, what are you most often like? What are you doing? What does it look like?
Yeah, I mean, 95% of the time I'm doing upper extremity surgery from hand to shoulder, hand, wrist, elbow, shoulder. My shoulder is mostly non-sports shoulder at this point. I've shrunk that part out of it. But basically that's the crux of it, full time up in Philly. And I can talk a little bit about that. I practice up at the Rothman Institute. So I operate in our affiliated facilities, including Jefferson and the mainline health system hospitals. I run our hand surgery fellowship as well at Rothman, and I wear a couple other hats. I most recently also have started doing some work beyond Jefferson at Drexel College of Medicine, where I'm now actually vice chair of orthopedic surgery there as we're starting to rebuild that department as well.
Hey, very, very busy, very accomplished, very busy guy. And we have a lot of residents that listen to this that are, trying to choose what specialty they want to go into. And we also hear that you take care of a lot of the athletes. Can you kind of tell us a little bit more about your interaction with athletes and athletes from which teams, and what does that look like for you?
Yeah, I'll answer your question in two parts because you did mention that most of the audience are folks training in orthopedics. First of all, they're smart folks, so they chose a great specialty. Orthopedic surgery is fantastic. And like I mentioned, I'm 95% upper extremity. The other 5% is basically I still do general orthopedic trauma. So I still take trauma call on the weekends and my designated days, which I've always enjoyed doing. And I always try to role model for my trainees that you can be a hand surgeon or a sports surgeon, joint surgeon, still be a fracture surgeon. And I think it's one of the best parts of orthopedic surgery. In terms of specialties, I think upper extremity surgery is a fantastic specialty for a number of reasons. One is I think that it encompasses all aspects of orthopedics in one limb. So you're doing fracture work, nerve work, tendon work, scope work, arthritis work, tumor work, young and old, athletes, non-athletes, the whole gamut of orthopedics. Secondly, people do well in upper extremity surgery compared to some of our counterparts in other specialties. Thirdly, we can do mostly outpatient surgery, which is the secret to having a good lifestyle in terms of people going home. I just was doing an inpatient case, and it takes me, just twice as long to do that case compared to that same case in the surgical center. So it's really and there's a ton of demand. I train fellows every year, and I'm shocked by the amount of demand it is for their services. And lastly, I'd say is you have a choice in terms of how complex of a practice you want to have. You can have a very bread and butter practice where you're doing carpals and triggers and distal raised fractures, or you can have a really complex practice where you're doing replants and reconstructions of amputated limbs or break complexity reconstructions or what have you. So it's really, there's a lot you can do with that career, and you're always like a valuable member of an orthopedic practice. Your last question was athletes. I've been very fortunate to be involved with taking care of pretty elite athletes. I'm the consultant hand surgeon for the Philadelphia Eagles, and was formerly the consultant hand surgeon for the 76ers. We just recently lost that contract this past year, so unfortunately not with them at this time, but have operated on the likes of Joel Embiid and all those guys before, and all the Eagles now that have upper extremity injuries. And I also cover a lot of other D1 sports and teams in the area like Villanova and St. Joe's. So it's an interesting thing. You're a sports fellow, so you kind of know a little bit about the culture of treating athletes. It's a different dynamic, and it's exciting. And frankly, growing up as a Philadelphia guy, it's an honor to be able to treat some of our best athletes.
Yeah. Hats off to you. Very accomplished and very, very busy. Very busy gentleman, and that's amazing to hear and note that you're doing all these things. And you're so busy that before we even met through email, I actually saw videos that you made on Jomi, the Journal of Medical Insight. That was actually my first introduction to you when I was a learner, sitting back and trying to learn different surgical techniques. And you crafted these beautiful videos, that really break down a lot of the surgery techniques, including this one here that we'll talk about today. What kind of got you involved in creating surgical videos and education?
I mean, fundamentally, it's because of my role as as a surgical educator. I trained in the early 2000s, and things have changed in that 20-year window since my own training. And I realized that most folks are really learning heavily from videos, different websites, social media, etc. And I just kind of embrace that reality, is that video learning is really kind of the thrust of what's going on. And I think where video learning is really, really most helpful is, frankly, surgical education, because it's a very visually intensive and manually intensive technique, and reading it is arguably less effective. So I kind of embrace that. And I have a lot of learners with me all the time, and they're cycling through every 6 to 8 weeks. So I felt like creating a library of common cases that I do would be helpful. And actually, I'll talk about Jomi, but prior to Jomi, I started my own channel on ViewMedi. It's called Rothman Hand Surgery, where I have basically probably 50 to 80 videos of all the common procedures that we do in the upper extremity. And then that kind of transition to my work with Jomi, which is a Journal of Medical Insight, which is a peer-reviewed journal for the surgical specialties, where video education and video articles is the medium that we use. And I'm editor for the part of the upper extremity part of the orthopedic section of Jomi. And it's not just orthopedic only, it's all the different surgical specialties as well.
Yeah, well, I just want to, if nobody's told you now, I would like to say thank you, because I definitely watch your videos in preparing for some cases in residency. So again, great videos for those watching, or for those listening to this. Definitely go check it out. And we can transition to today's topic, where we're talking a little bit about distal bicep tendon injuries, which I've seen a lot and a lot more. I saw a lot in residency, and now I'm seeing a bunch in my fellowship as well. And so I guess in your experience, what patients are coming to you with this? Who are you seeing that are having these distal biceps injuries?
Yeah, basically people like me. So middle-aged men. That's the kind of the largest bulk of the patient population. It's almost rarely in women. Interestingly, it's almost always men, and usually in middle age. So you're seeing people in their 5th, 6th, 7th decade of life that are presenting with these injuries.
Yeah, and what is the typical mechanism of injuries, of how this occurs?
Yeah, the classic teaching you're going to read about is the eccentric contraction of the biceps, where the biceps is firing but also elongating, and that causes that tension. And the weak link in the chain is often the distal biceps. It can be the proximal biceps as well, which is, interestingly, we treat it completely differently than the distal biceps, which I always found to be an interesting paradox. You're lifting something heavy, like in this image. It's often a sudden motion or jerking motion, is a sudden extension, sudden firing. And oftentimes it's just a pop, and they feel that. And there's, interestingly, it's tender in the beginning. It's painful in the beginning. And the classics, we can talk about the exam features, but you're typically carrying something or doing something sudden like that.
Yeah, go for it if you want to go into exam features. But just like you said, middle-aged man, typically carrying something eccentric.
Yeah, the classic things you'll see on exam is, first, the history, like they're lifting something, felt a pop or a strain. It tends to be very well localized in the anterior elbow. When people complain of elbow pain, common things are common. So you're often looking at the lateral epicondyle, medial epicondyle. But this is often right in the anterior aspect of the elbow. And you'll often see bruising. That's a big tell. So you'll see a bruising and often in the anterior aspect in the antecubital fossa region, which is a big tell. And obviously, probably the biggest tell is deformity of the bicep. So if it's a fully ruptured and retracted biceps, you can see it from the door when you walk in when the bicep is sitting really high. But that's not always the case. You can have a complete biceps tear with minimal retraction if the lacertus is maintained, or no deformity again if there's a partial tear. But so when it's completely torn and retracted, it's obvious, but that doesn't mean that if it's not, that there isn't possibly a biceps injury. And on exam, you can do a few things. You can check resisted elbow flexion. I find that generally is not that helpful because the brachialis is your stronger flexor, and that's obviously intact. But resisted form supination is the tell. Your supinator, your biceps is your primary supinator. And the moment you isolate them and have them supinate against resistance, they'll fail and you'll get that immediate complaint of pain and evident weakness. And then the common thing, as you've shown in your PowerPoint here, is the hook test, where you can physically try to hook your finger around the biceps tendon when they're firing it. And sometimes it helps to compare from side to side for any of these things, particularly with the hook test, because some folks are thin and you can really feel their biceps tendon, and others you really can't. So I don't find the hook test as useful necessarily, diagnostic, if you will, because like I mentioned, sometimes they'll have a complete tear that's not retracted or a partial tear. The hook test may be normal in those patients, right? But when you go against resisted form supination and bruising anteriorly, those two to me are common tells, short of obviously deformity.
Yeah, and you mentioned something about partial tears. I want to get back to that in a second, but can we briefly, because you mentioned the lacteris and other kind of anatomic features or things to know about the anatomy of the distal biceps. So can you kind of just quickly just go over what is the relevant anatomy of the distal biceps that we should think about, that we need to know when we're, especially when we're talking about just like, anatomical features? This is what you should know.
Yeah, I mean, there's a number of things you need to know. First of all, the bicep tendon is actually pretty small relative to the biceps musculature. So one of the reasons why we often see it more commonly in folks who, again, anyone can get it, particularly middle-aged men, but we'll often see it more in folks who are heavy lifters, kind of later in their careers, particularly if they were using steroids, because there's this kind of like imbalance with this size and strength in the delta. I'm sorry, the biceps relative to a relatively small biceps tendon, because the tendon doesn't hypertrophy over time like a biceps musculature can. So it's often the weak link. There's a short and long head of the biceps, which frankly, anatomically is hard to discern the different distinction of, other than just knowing from like an in-training perspective that the long head inserts more posterior relative to the short head on the biceps tuberosity of the proximal radius. So from an external perspective, again, you got your biceps, you've got your biceps tendon. From an internal perspective, the kind of the big things you need to know, and we can get into this, is one is a lateral antebrachial cutaneous nerve is very close and adherent to the biceps tendon. That can be irritated with and without surgery, but commonly with surgery because you have to retract it out of the way. There's a lacertus, which is a confluence of fibers that extend from the medial flexor mass to the biceps tendon, which can kind of tether it in place to some extent. And that's something that we often have to mobilize, particularly in chronic cases, to fully mobilize the patient. And then going deeper, obviously, the big thing we worry about is the posterior interosseous nerve, which is always lurking really nearby when we're exposing the radial tuberosity. We can talk more about that as we get into the surgical aspects.
Yeah, so perfect. So say you got a 50-year-old male was helping his friend lift a TV, heard a pop in his arm, and he came to your office, you examined him. He had a little bit of swelling on his elbow, and he got a really a loss of supination. What are you getting next? Are you getting any type of imaging next at all?
Yeah, great question. I think it depends. I don't always get an MRI for these. Some are as clear as day. Like I said, the deformity and the bruising and the mechanism of injury, I won't. For those that are in between, where I'm not convinced, whether it's complete tear or not, I will get an MRI. You could get an ultrasound too. It depends where you are. I have ready access to an MRI. I don't really know how to get ultrasounds or do ultrasounds or read ultrasounds, but I can read an MRI. So an MRI is my study of choice.
Yeah. And and for, I guess we can talk about it in when we get to actually. So if you have a patient that's say is 8 weeks, say there's some weeks out, say that the injury happened 8 weeks ago or 12 weeks ago, it's a certain time period where you're like, okay, well, for this one, I'll get an MRI to assess other qualities, or because that may be different than your person that comes in 3 days after lifting the, whatever it may be, and has a pop and, is really weak. Does that change at all if you're going to get an MRI?
Yeah, I mean, so broadly, I'll admit I'm not a big MRI orderer, if that's a word.
Okay.
For certain body parts like the shoulder, I think it's a mainstay, and for myself as well, when you're looking for soft tissue injuries and derangement of the shoulder, like in the wrist and hand, I very infrequently get MRIs. The elbow, I think it can be very handy, and broadly, we get an MRI for two reasons. Most of us don't need it for the diagnosis; it's mostly for, characterizing the diagnosis. So complete tear, partial tear, et cetera. And then retraction of some amount. Is there any retraction that's occurring as well? Has occurred as well. And then some associated injuries that may be mimicking it, this injury. But for the most part, these are pretty straightforward. So to answer your question more specifically, if we're dealing with a chronic injury, I do want to see how far the tendon is, how much it's retracted. And you'll see some pretty interesting MRIs over the years. Like I've seen MRIs where the tendon is like flipped up underneath the biceps, like mid-brachium. It's really amazing what these things can really pop proximal. So kind of knowing where to find it is helpful. So in an acute stage, it helps me confirm the diagnosis, and helps me know is it a partial or a complete. And then for like subacute or delayed, it also helps me make the diagnosis, and also helps me better understand where the tendon is, and does it have a chance to get back to the tuberosity for a primary repair, or are we augmenting it with a graft?
Yeah. Okay. Perfect. And so let's kind of go to treatment. So what are your treatment options? And then one for, I guess, for complete tears. And then you also mentioned partial tears. I want to see kind of your treatment options for there, if you treat those the same.
Yeah, partial tears actually I think is a more interesting thing. But for complete tears, it's either operative or non-operative. And, I would say that my observation in the past 20 years or so has been that the pendulum has swung heavily towards operative. I had a fellow a couple of years back who trained at a very reputable program where they said that they don't repair any of these, which I thought was fascinating. And I would say probably at our center, we're probably aggressive in treating these. And I try to be as practical as I can with this. And I let people know, like, listen, if you have this rupture, you can treat this non-surgically. It's not going to shorten your life or cause you any long-term problems, but your biceps will look different from side to side, and you will have some decrease in strength. Biceps flexion strength typically only decreases about 10%. So that's really not measurable for most folks, not perceptible, I should say. But supination strength, turning against resistance or with power, is typically lost by about 50%. So it depends on the individual, whether they want to do this or not. My observation in my own practice that men want to have it fixed. They just don't like the idea of not having their biceps in place. And so I think there's a bias towards that, but I think it's important to know, particularly for in training purposes, it can be treated non-surgically. And for partials, that's always really interesting. So firstly, I would say that, and this is speaking for myself only, I can't quantify partial tears on an MRI, 10, 30, 50, 80%. I can't really tell, particularly in the acute period. It's very difficult to tell. And similarly, I've gone in on partial tears where basically it's like one or two strands intact, or there's a pseudotendon intact, but the main tendon has been long since retracted. They were all read as partial tears. I just think it's challenging for us and the radiologist to really know what a partial tear truly is. But broadly, I'm not opposed to treating partial tears non-operatively. My general approach to this is, if someone comes with a partial tear, I say, listen, it's a partial tear. These can, quiet down. We can rehab this, and we can see how things go. It's not time sensitive. If things don't go well and it keeps hurting or it ruptures, well, then we know what we need to do. We can proceed with the repair. Those options have not gone away. They're still there. But if it happened to get better, you happen to get more comfortable, then that's perfectly fine too. So I allow non-operative treatment to start, and I generally encourage it. And if they either fail it or are persisting pain or complete to a rupture, then we go to repair.
And so you mentioned therapy. So let's go down to non-operative routes. So say you're treating this non-operatively. What does that look like? Are you giving them a hinged elbow brace? Are you limiting their range of motion with flexion? And then when are you starting off with therapy? What is your non-operative treatment?
Great question. So when the folks listening who are starting their practices, one of the hardest things when you start is understanding how to prescribe therapy when you get into practice. All the broad milieu of orthopedic injuries we treat, most folks when they're training really don't understand how we're prescribing therapy, what advice and directions we're giving our therapists. So that really matters. What for me, for distal biceps, I don't limit range of motion. I know people do. They block out the terminal extension, which makes sense. So I think it's fine to do. I really focus on progressive TheraBand strengthening, which is less stressful for the tendon, but still allows for some conditioning and adding modalities to it as well.
Okay, cool. That's good to know for the non-operative treatment. So that's non-operative treatment. Now let's kind of dive a little bit deeply into operative treatment. What are some of the different options for operative treatment? You know, we can break it down into approaches, and then we can break it down into how you're going to fix, how you're going to end up fixing the tendon in your specific technique.
Yeah, we often dichotomize biceps repair into the 2-incision, 1-incision families, and the 2-incision is traditionally the Boyd-Anderson technique, and that picture you have here is of the Boyd-Anderson technique, where you identify your tendon anteriorly, you tag it, then you use a large hemostat or coker, and you deliver it dorsally, hugging the radius, making a separate incision on the back of the radius, creating a trough in the radius, and through drill holes, delivering that delivering the tendon into that. That's your 2-incision. When I was a resident, that's how my attendings did them. And I think over time, the 1-incision technique has become popularized as well, which is a variation of a few different things. 1-incision might mean 2 suture anchors placed in the tuberosity, and then you run the sutures up and down the biceps tendon, and you pull the lead limb and you tie off. The other option is to do the endo button technique, where you attach a button to the tip of the biceps tendon. I'm looking at your picture here. And the third is what you have here, I think, is the biceps button or biceps slide technique, where you're putting a whip stitch through the tendon, then through a button that you can kind of slide. So then you enter the proximal radius, and we can talk more about the technique a little bit, but I'm just giving kind of broad overview first. You push the button through the back cortex, and then you slide the tendon into the hole, into the trough you've created, and then you tie it off. At that point, you put a tenodesis screw to reinforce it, and you can tie off over the tenodesis screw as well. I've done all those techniques across my training and my practice, and I've graduated to just using the bicep slide technique. That's been popularized by Arthrex. I have no conflict of interest with them. I find it's a very slick technique. It can be done all through 1-incision. I also find that it's safer. I always felt that the 2-incision was kind of scary because it's a blind stab, essentially through the middle of the forearm. And as someone who does a lot of nerve surgery, I've been on the other side of people having nerve injuries that I've had to manage with that technique. I know it's a tried and true technique. I'm not judging anyone who does it. Even in my own practice, it's almost 50-50. Half of them are doing it 1-incision, half are still doing 2-incision. So it's perfectly fine. It's proven to work. But in my own hands, I find that the 1-incision is safer, I'll just say, because I see down to the tube. I dissect down to the tuberosity, debris the tuberosity, I expose it. I can keep the forearm in full supination to get as anatomic as possible. I can make sure to retract where the push interosseous nerve is going to be. I place my wire across the guide wire across the radius in a direction away. We cheat ulnar away from the push interosseous nerve. And you can really dunk that tendon in with a lot of confidence, and you can see that sucker drop in there. You tie it off, and then you have 2 more points of reinforcement. So you actually have 3 points of reinforcement with that technique, which is good. When I was doing the suture anchor technique, you would do the repair, and as you were closing, you just kind of saw the biceps tendon start to kind of pull upward. And I would imagine that it still worked, but I guess like a pseudo tendon would form around it, but it just wasn't as satisfying as when you can lock it down into the bone with the 1-incision as bicep slide.
Yeah, and I've seen, at least I think now at this point, 4 different ways of people doing just a 1-incision I've seen a transverse incision at the crease of the elbow, a transverse incision about 3 centimeters distal to the crease of the elbow, a vertical incision, and then a transverse, which you can extend up medially in case you need to do an allograft or something. Which one is your preferred technique for?
Yeah, I've seen all those
too.
Yeah, I'm with you. I've seen all those as well. I just do a longitudinal, starting probably a centimeter distal to the antecubital fossa crease, antecubital crease, and go straight distal. The nice thing is you're often not, when you do the transverse, you could be too proximal, too distal.
Yep.
If you do longitudinal, you can extend whichever way you need to get to where you need to be. So you're not wrong per se, but you can be too proximal, too distal. And the mistake, people get into trouble with the surgery when they're not adequately exposed. You just have to expose adequately to get down there to be safe. You just got to be safe. And I think one of the things that tends to separate hand surgeons and nerve surgeons like myself and other orthopedic surgeons is that we're not afraid of nerves. And most of us like to know where they are, so we're protecting them. Whereas I find a lot of folks traditionally orthopedics are just afraid of the nerves. So they don't want to see it, and the less they see, the better. But that's when people get into a little bit of trouble. Starting from the LABC down, like the first thing I'll look for is the LABC. I don't go aggressively neurolysing it. I just want to spread and see, okay, there it is, so that I can put an Army Navy around it. Because one of the most common problems after these cases is LABC irritation or radial sensory irritation. So I just want to know where it is, mobilize it. It's often caught in some of the hematoma, and just kind of retract it. Going down further, the vascular leash is there of Henry that people get in trouble with that. There's a lot of ways to manage that. People like to do clips, which I think is fine. I just tie things off as I go down. But I go right down to tuberosity, direct view. No guesswork involved with it. And I visualize the tuberosity. I don't put Homans in there because that's when you can get in trouble with the PIN, particularly on the radial side of the radius. So I will not put any Homans in there, although it's very tempting to, because that would be really helpful. I'm always using Army Navies, which is more annoying, but it's safer. And I go right down to tuberosity. I always have an assistant for this case who's max supinating, and I'll yell at them a few times during the case, palm all the way up, palm all the way up. Because if they get lazy and they're not paying attention, now you're preparing the wrong side of the biceps tendon of the bicipital tuberosity. So palm all the way up, two Army Navies in, and then a debride with the Ronger, and then proceed with guide wire and the drilling.
Yeah, I was gonna say that you just touched on all the high points that I was gonna mention.
I don't want to steal your thunder. I'm sorry.
No, this is your thunder. You did perfect. You got all the points, especially even the board style questions, because they'll ask us the most common injured nerve, which you mentioned was the LABC, lateral antebrachiocutaneous nerve, and then you also talked about the PIN nerve and how to avoid that. And again, for those listening, you have a great video on how to do this on Jomi. So definitely, those listening, they want to see how you do it, go and check that video out. Very, very in depth and very technical. And so we're, I guess, looking at outcomes wise, how in your experience, how are patients doing? Are they getting all their supination strength? They're getting all their flexion strength? Are they going back to their sport? Are these typically the weekend warriors that are getting back to it? How are these patients typically doing?
Yeah, I tell people I anticipate a full recovery from the surgery, barring any unforeseen complications. I think from the research perspective, like you put on this, is that the book answer is 90% recover flexion and supination strength. There's often a measurable difference, but not often a perceptible difference, if you know what I mean. So there's a measurable distance, and that's also comes into play with. There's been arguments made that certain techniques provide better supination strength. Ultimately, one of the main arguments for the Boyd Anderson is because it is a more medial insertion of the biceps tendon relative to the tuberosity that gives you more supination power. Yeah. Whereas the one incision technique is always you always enter anterior to the tuberosity in supination. So the argument is you get less supination strength. Boyd Anderson, you enter more medially, so you can there's more of that cam effect. And I think that makes total sense to me, scientifically and anatomically. I think don't quote me. I can't quote it, but I believe that's been borne out in biomechanical studies as well. But I don't think it matters from a patient perspective, those type of differentials in strength. So for me, it's not enough to change it. And moreover, technically, I find that one incision just much better for, at least in my hands, but I don't think it's wrong. But like I said, and one of the strong arguments for the two incision is the arguably better cam effect and supination power.
Right. Yeah. Yeah. And so you mentioned a little bit earlier, or I guess we briefly talked about, we talked about getting, for chronic tears, we talked about imaging and seeing kind of how far retracted it was. And so, there's sometimes I'll see, cases posted where you're going to do a distal biceps and you may do an allograft augmentation. In your experience, when should you be prepared to do one? And then are you doing them? And then what is your indications for it?
Yeah, I think anytime you're dealing with a subacute biceps tendon, so I would say 4 or more weeks out, I think you should have a graft nearby, an Achilles graft or a semi-T graft. I typically use Achilles nearby. That's when you could get into trouble, where it could be really retracted and it's not gonna make it down back to its footprint at the tuberosity. I've done patients who are 3 to 6 months out, and there was no question I was going to use a graft right going into it, but there's kind of that subacute 4 to 6 week window is kind of this gray area where it's useful to have. So just have it within ready use, because it sucks when you need a graft and it's not available. And depending where you operate, plenty of places have plenty of grafts and plenty of places don't. So like you just have to make sure you got what you need just in case.
Yeah, and what is how do you fix it? Your technique for using the allograft? How do you actually? I know there are many different techniques. Some people put a split in the Achilles and bring it up and suture it to the tendon. How do you do it?
I don't know if there's a perfect technique for it, but I take the Achilles tendon without a bone block, no bone block, and then I will overlay. So first of all, there's a pretty big exposure, so I go curvilinear around the lateral aspect of the biceps, elevated so I can see the distal part of the biceps, mobilize the tendon, make sure I have a good view of LABC, so I'm not going to capture that in anything. And then I lay the Achilles tendon over top of the biceps and biceps tendon, kind of make sure there's adequate overlap between the native tendon and the graft, but the graft is going adequately distal past the graft. I'm sorry, adequately distal past the native stump, I should say, because it's the graft that's going to be ultimately inserted. And then I'll whip stitch them together as one, so that the graft and the native tendon are whip stitched together at one. So for a period of time, they were together. And then when you go past the native tendon, it's just going to be the graft tendon. And the proximal part, I just sew in, I just fan out the biceps. I'm sorry, fan out the proximal part of the Achilles graft and sew it to the biceps musculature. That part is probably not necessary. It just kind of covers everything nicely, and there's more confluence, if you will. I doubt that makes any difference, really. The hard thing to know is how long of a graft that you need. And you don't want to make it too short where now you have another short graft, so now you're still stuck. You don't want to make it too long and there's no tension on the repair, right? So it's a little bit of the Goldilocks. It shouldn't be too short. It shouldn't be too long. So my general rule of thumb is that the tendon should be able to touch the tuberosity at least at 90 degrees. And if you can touch the tuberosity at least at 90 degrees, then in time that should stretch out. And again, it's a hard tell sometimes. But if you're putting it in and it's totally loose, then it's not going to do anything. It's got to be under some tension.
Okay, so you want it at least at 90 degrees where it touches the tuberosity.
Yeah,
and you
because there's also gonna be creep in this, right? So it's graft on graft. They're not going to incorporate right away. So there's going to be a little bit. They're just collagen. It's just going to stretch a little bit. So I want to put these in a little bit tight, because I know they're going to loosen in time anyways.
And what's your post-op protocol for? Was it the same for both, or what was your protocol?
Yeah. I think that I'm probably a little more conservative with my post-op protocol compared to other folks. I think I've heard all sorts of post-op protocols from colleagues, and there are many folks that put people on a soft dressing and get them going. I think that's probably fine. I'm a little bit conservative with this because I don't want to have to go back in on these, and people can be, if they don't have any guardrails, they can be pretty aggressive after these type of surgeries. So what I typically do is I put them in a post-op splint and get them into the office within a few days of surgery, 2, 3, 4 days, and I get them in a hinged elbow brace. And I have in a hinged elbow brace for about 4 to 6 weeks where I'm dialing in progressive extension. They have full flexion the whole time in the brace, but I'm kind of dialing in progressive extension. So they get the full extension over 4 to 6 weeks. So they're kind of stretching out the repair slowly. And we're also preventing an inadvertent extension of the arm, like at sleep and other times. They have the brace for 4 to 6 weeks. I actually don't do PT with them during that time. I'm just letting the tendon some time to take, if you will, and that healing to occur. And then I start PT at about 4 to 6 weeks, and it's progressive TheraBand strengthening, and I don't introduce weights till 12 weeks. So I don't have to do any free weights till 12 weeks. And I always tell my patients tell them TheraBands is not sexy, but it's very effective. It gives you nice, consistent tension on the tendon without that kind of herky-jerky motion that you can get with weights. And they're deceivingly effective because as you get up in bands with greater resistance, they're pretty tight and they're hard to move. And then once they get to 12 weeks, I cut them loose. They can do whatever they want. I let them go to the gym. I let them lift. And I just advise them that go slow in the beginning. Don't start off right where you left off with your curling and whatever you're doing. And I advise them it's going to be mostly curls and row type maneuvers that are going to get you. Press will not hurt you. It's things that you're bringing to yourself. Any kind of curling, rowing are the classic ones that people are going to feel that some strain on their repair. So go slowly. And typically at 3 months, folks are not 100%. Usually they're about 70% in terms of their recovery feeling, strength feeling, et cetera. And I tell them it takes about another 3 months or so before you feel like you've fully gotten there. But I unrestrict them at that point, let them get there on their own.
Any difference if this is a professional athlete in your post-op protocol?
Oh man, with the pros, we go so fast, it's crazy. It's crazy. There's a lot of pressure on these guys, these poor guys to get back to play sometimes. So I feel like almost anytime we deal with a pro athlete, which is very frequently, it's almost half the rehab strategies to do for the general public. And sometimes that's born out of because, there's obviously a lot of pressure for them to play. Some of it's because these guys are generally in top physical shape. And also because they have, unlimited resources of people kind of like monitoring and enhancing their recovery. So, but we tend to go even faster whenever possible.
Yeah. Yeah, that's awesome. Well, Ilyas, this has been a great episode. I learned a lot, still just from speaking to you about distal biceps injuries. And again, commendments to you and congrats to all that you've done and all that you'll continue to do and everything that you're working on. Any last words that you want the audience to know about distal biceps injuries before we wrap up?
Yeah, I mean, it's a fun diagnosis. It's a great surgery to do. Patients enjoy it. It's something you can do that really helps restore people, which is really the crux of what we do in orthopedics. And you mentioned that are the sites where they can watch these videos. We have a great article of this in Joe May Journal of Medical Insight. And also if you go to ViewMedi, which is completely free, I have a channel called Rothman Hand Surgery. I have all those videos available to anyone to view whenever they like.
Yeah. And where can the people listening to this follow you if they want to just learn some more or just follow you just to tune in to see whenever the next, anything else that you have going on?
Sure. I'm definitely active in some social media stuff. So I'm on Instagram at Ilyas Ortho, all one word. On LinkedIn, just my first name, last name, Asif Ilyas. I'm on Facebook, but I don't really use it because I don't really like it. So my main two are Instagram and LinkedIn. I definitely post a lot of stuff, interesting cases, and news related to orthopedics and other things in medicine and surgery.
Well, Dr. Ilyas, again, thank you so much for coming on the podcast. It's been great. Learned a lot talking to you, and thanks so much for taking the time out of your day to come on the podcast.
My pleasure.